Hello viewers. In this video, we are going to discuss about the second part of the wound assessment. In my previous video, I have spoken about the wound assessment, why nurses should be aware of the wound assessment, and there are different aspects of the wound assessment, which I have divided into two different parts. The first part of my video included location of the wound, age of the wound, type of wound assessment, tissue involvement, moisture, infection, and wound ages. Whereas in this video, I'm going to discuss about size of wound bed status, necrotic tissue, wound exudate, peri-wound area, odor, and pain assessment. So let us move into the video. Before that, let me discuss about the objectives of this video. At the end of this video, viewers will be able to accurately measure wound, explains the importance of wound bed status and tissue type, assesses peri-wound area carefully, explains the significance of wound odor, and understands the importance of pain assessment. So let us go into the details of the assessment. The eighth aspect, there are 7 aspects which I have discussed in my previous video. The eighth aspect of the wound assessment is the wound size. Accurate, complete, uniform, and consistent wound size measurement required to establish diagnosis, plan of care, and to evaluate the wound healing. Wound size measurement includes 3 components: area of wound, depth, and volume of wound. Measuring wound dimensions including measuring width, depth, and length. When the length is multiplied by the width, will provide the approximate surface area, whereas when the wound is measured based on the length, width, and depth, which provides the approximate volume of the wound. So it is always better to measure area, depth, and volume of the wound to provide the accurate measurement. Nowadays, various electronic devices also available to measure the volume of the wound. When measuring the size of the wound, we also need to include the sinus tract tunneling or induration. Tunneling is otherwise known as undermining, which is an area or space parallel to the skin tract, which are narrow areas which may extend beyond the depth or edge of the wound, which is assessed, measured, and documented to guide treatment related to dressings and packing, and to establish a baseline to assess the wound healing. So when we measure the wound, we need to consider certain tips. Always define specific procedures to determine wound age and total wound area. Take measurements the same way each time from noted reference point on the body. Use same units of measurement and terminology for each measurement. Have same person to take measurement. Use an assistant to record measurements, and use a prepared form if it is available in the institutional area. So here, the length as well as the width of the wound is being shown. Here, when we measure the length as well as the width, it provides the surface area. When the length is multiplied by width, it provides the surface area. As I said earlier, if you measure the depth of the wound, it provides the volume of the wound. So next we'll see certain other devices which helps in wound healing. The first one is the wound tracing, which is otherwise known as the digital planimetry. This is a transparent sheet which can be used with the help of the marker or pen to trace the outline of the wound directly on this sterile transparent sheet of film. It is then a simple matter to compare the one measurement with the other. The advantage of this using this tracing paper is it is a relatively painless one, but it also has certain disadvantages where sometimes we cannot clearly see the wound boundaries, or which makes this measurement as less reliable and less accurate. The alternative to this tracing paper is using the photography. When we take the photography of the wound, we need to consider certain points. Use the good lighting source. Position ruler to show the relative size when the camera is on. Use a string of known length and position camera from the same distance every time the photograph is taken. Use ID of the patient on the wound margin like name, location and date of taking the photography. And use a ring flash attachment to reduce the shadows. Use an assistant to position the person on the ID side. Benefits of taking photography is it prevents the litigation and it acts as the permanent record of wound. Serial photos can show progression towards healing, which can be used as a teaching tool. And this is the more reliable comparing with the other method of tracing. Accurate, it improves measurement consistency, and it has no contamination, no damage to wound bed, and it is less painful procedure. Next, we'll see measuring the wound depth. Depth means distance from the visible skin surface to the wound bed. Always we have to use the extent of tissue damage when measuring the wound depth. And this is also the crude method of tracking the growth of granulation tissue. When measuring the wound depth, find the deepest site and measure the wound depth. How do you find the greatest depth? Place a cotton tipped applicator into the wound at the deepest point. You can mark or pinch at the cotton tipped applicator at the skin level. Then you can compare that applicator to your ruler to measure the depth of the wound. So when we measure the length, width, and depth provides the accurate measurement of the wound volume. The next method of using the wound measurement is Clark method. And this is most common type of measurement where it provides the linear measurement using this Clark method. In this technique, we can measure the length and the greatest width and greatest depth of the wound using the person's or the patient body as a measurement, where the patient body acts as the face of an imaginary clock. Document the longest length using the face of the clock. This is the face of the clock, and measure the greatest width. On the feet side, the heels are always at 12 o'clock position and toes are always at the 6 o'clock position. Document all measurements in centimeters, that is length multiplied by width into the depth. Remember, sometimes the length will be smaller than the width. So here is some activity for you just to look and find out the longest length and the width. Hope you are able to find out the longest length and the width. Let me give you all the answer to this. And in this wound, this is the longest length and this is the width. Same way, you can see all the longest length and the width are being marked with the arrow. Next is the tunneling. So tunneling is a separation of the facial planes which is leading to the sinus tract. You can see where there is a sinus tract or the tunneling is formed. It usually involves a small percentage of the wound margins. Tunneling are usually narrow and long and seems to have a destination. If you insert a cotton tipped applicator or a piece of long material, thin one, you can see that it enters into one part and comes out into the other area. If this kind of things are found on the wound, then that called as the tunneling. Next is the undermining. Undermining usually involves a greater percentage of the wound margin comparing with the tunneling, which are shallow length than the tunneling. It usually involves the subcutaneous tissue, and you can find an erosion under the edge of the wound. The edge of the wound will be eroded, and it also will appear as the rolled edges. Here is an activity to find out whether these wounds are having the tunnels or the undermining. Can you see which is the one in this 4 area, whether these are tunnel or undermining? Let me show you the answers. The first one is the undermining. You can see the wound edges are rolled, whereas this is the sinus tract, which indicates there is a tunneling. Again, this wound is undermined, and this is the tunneling. So hope the viewers will be able to identify the tunneling and undermining. And for your information, these images are being taken from the Google, and this is used only for the educational purposes. Next, wound measurements are made in the centimeters. And the first measurement is oriented from head to toe. The second is from side to side, and third is the depth one. And you can see there is a head to toe and the side to side, and you also able to identify the tunneling as well as the undermining in this wound. If there is any tunneling or undermining, this should be charted in respect to a clock, with the 12 o'clock being toward the patient's head. And you know what is tunneling? We usually assess the tunneling with the help of the cotton tip applicator, and undermining is assessed with the rolled edges and the lip around the wound. And here you can document the wound as full thickness, red, round, 7 centimeter into 5 centimeter and 3 centimeter, with a 3 centimeter tunnel at 7 o'clock and 2 centimeter undermining from 3 o'clock to 5 o'clock. So this is the wound we can see. Again, I repeat here. Here, this wound will be measured as full thickness and red color wound, and the 7 centimeter length and the 5 centimeter width and 3 centimeter tunnel, and at the 7 o'clock position, and 2 centimeter undermining at from between the 3 to 4 o'clock, 4 to 5 o'clock position. And this is the way you can record the wound measurement of length, width, including the tunneling and the undermining. Next, based on this measurement, you can use this measurement to track the healing. Okay, how do you assess the healing based on the wound measurement? Always we need to re-evaluate the rate of wound surface area closure to help determine whether or not the wound is closing at an expected rate. The precision of wound measurement and the method of calculating the rate of change can influence the clinical decision in selecting the treatment modalities. And how do you assess the rate of healing over time? In general, they say like 20 to 30% reduction in surface area over a 3 to 4 week period is a reliable predictive indicator of chronic wound healing. So next, we'll see how to calculate the surface area reduction. Suppose you have to calculating the surface area at the admission of patient, then calculate the surface area at the current time. Suppose you are going to assess the surface area reduction today. So what is the surface area at the admission and what is the surface area today, and what is the difference between the surface area on admission and today's position, and multiply by 100, which gets the surface area reduction. So here are some of the examples. So what is the reduction in this wound surface area from the following wound? Suppose in the A wound at admission, the patient is having 15 centimeters square, whereas 1 month later, if the patient has 23.7 centimeters square, there is a change in the plus 58%. Like that, if you calculate the change in the size of the wound at admission time and 1 month later, and we can see these changes. These are some of the examples. Can you identify where there is a greatest reduction in the wound size? Yeah, can you, can you identify? Yes, it is the 58.9. The B wound is healing based on the expected rate. That is 20 to 30% of reduction in the wound size over a period of 3 to 4 weeks. The next component of wound assessment is the wound bed status. Wound bed status will help us to identify how well the wound is progressing in the healing process. Healing wounds are characterized by increasing amounts of granulation tissue, which may be later replaced by epithelialization. Accurately, difference accurately differentiate between wounds that are granulating and those are not granulating. The type of tissue in the wound base may be described as granulation, slough, or the eschar, and we also have to know the approximate amount of the tissue. If there is a significant amount of slough, which may be yellow, green, white tissue, or eschar, which may be brown, black, which appears as the leathery tissue. Either the slough or the eschar signify a wound in the inflammatory phase. Certain wounds may be clear, but which are not granulating. This is commonly seen at the end of the inflammatory phase when debridement is complete, but granulation tissue formation may not have taken place. Because many wounds contain a mixture of tissue types, wound bed status is best represented by the percentage of each type of tissue covering the wound. For example, we can say 50% of granulation tissue, 50% clean non-granulation tissue will provide you the accurate status about the tissue that is covering the wound. And we also can label a clean non-granulating wound as a granulating wound, mistakenly indicate that the wound is actively healing and is on track. In fact, non-granulating wound is not healing, which may require further evaluation and further intervention to aid the progress of the wound. Formation of granulation tissue is important differentiator among the wounds. Either can be classified as non-healing or early healing or partially granulating or fully granulating. Inaccurate assessment of wound bed status can result in reduced treatment cost and the reimbursement. And coming to the characteristics of tissue type, as we discussed, either the tissue may be the granulation tissue, clean non-granulating tissue, or new epithelial tissue. And here you can see in this wound, the granulation tissue is typically a deep pink or red, which may be characterized by irregular granular surface that may resemble like raspberries. Whereas clean non-granulating tissue is deep pink, red, or smooth. You can see non-granular, or sometimes it may appear striated with the fibrous muscles exposed. The third type of tissue is the new epithelial tissue, which may be light pink or slightly lavender and dry, which may be full thickness wound. New epithelial tissue migrates from wound edges to gradually cover the granulation tissue. And you can use the time criteria to measure the type of tissue type, whether the wound is viable. In case of infection, there will be a bacterial balance and reduced inflammation. M for moisture balance. E for edge, that is advancing epidermal margin, wound stage decrease. So the time criteria will help you to assess the wound tissue type. Next, we'll move on to the assessment of necrotic tissue. And we know necrotic tissue is the non-viable tissue which is present on the wound. And this may be severe in the underlying damage. This necrotic tissue will take longer to close the wound, and which may also impact the wound healing, as it is a physical barrier to granulation, contraction, and reepithelialization. And most of the time, this necrotic tissue can harbor the bacteria. So the necrotic tissue, it has various color, consistency, and adherence to the wound bed. Based on the color, you can observe the necrotic tissue. Either it may be white or gray, or yellow fibrinous, yellow or tan slough, black or brown. If it is black or brown, we call it as eschar. If it is the yellow or tan, we call it as slough. Consistency of the necrotic tissue may be a mucinous one, soft or stringy, soft or soggy, or the hard one. Whereas adherence of necrotic tissue may be clumps, loosely attached to base of wound only, firmly adherent at base and edges. So based on this, necrotic tissue can be classified as red, yellow, or black. Red necrotic tissue, where wound bed is clean, tissue is red or pink. Here, when that wound tissue is red in color, then the goal of the wound management will be maintaining the moist wound healing environment. Suppose if the tissue is yellow in color, which indicates the wound bed has slough or fibrin, which may be present, or the wound tissue may be combo of red, pink, or ivory, canary, yellow, green, depending on the infection is present or not. Not all yellow is bad, whereas sometimes granulation grows through yellow fibrin and a healthy tendon may appear as white or yellow. So we need to consider and assess the other factors before we conclude that if the yellow tissue is present. If the yellow tissue is present, the goal of the treatment will be maintaining the moist environment whilst managing excess exudate and remove slough. The third type of wound tissue may be a black one, which indicates non-viable tissue. Color may be dark brown, black, or gray, or may not be red or pink, or canary yellow, green. In this case, the goal will be remove the non-viable tissue except stable eschar on the heel. The type of non-viable tissue present can help identify the phase of wound healing that the wound is in, and as much can help to direct the treatment options. Next, we will see the difference between the slough and the eschar. Slough indicates less severity, yellow or tan mucinous or stringy material, loosely adherent to wound bed. If non-adherent, will be scattered through the wound. This is the slough. Whereas eschar, this is the eschar, which indicates deeper tissue damage, which appear black, gray, brown in color. Usually adherent or firmly adherent, may be soggy or soft. Sometimes it may be hard and look like the leathery tissue. Here is an example of slough or eschar. Can you identify among these four wounds which are the sloughy wound and which are the eschar? Hope you are able to identify. It's the next aspect of wound assessment is the wound exudate. There are different types of wound exudate which we will describe based on the color and the consistency. A serous wound exudate will indicate which may be clear, light, yellow, thin, or the watery in nature. Whereas serosanguinous wound exudate may be pink in color, which may vary from pink to light red, and the consistency will be thin and watery. Whereas sanguinous wound exudate appear bright red, again it will be thin and watery. Purulent exudate appear dark yellow, tan, blue, or green. The consistency will range from thin to thick, which may be watery or it may be opaque. Whereas other exudates are sometimes over the dressings and the topicals can alter the appearance of exudate. Example, silver, cadaxomer, iodine, etc. may alter the type of wound exudate. The amount of wound exudate can be from no wound exudate to the large amount of wound exudate. If there is no wound exudate, that means no visible exudate on the dressing or on the wound. We can say the scant, no measurable exudate on the dressing. However, the wound tissues are moist. If the exudate is occupying less than 25% of the dressing and wound tissues are visibly moist, moisture is evenly distributed throughout the wound, then you can say there is a small amount of the wound exudate. Whereas moderate amount of wound exudate characterized as where drainage involves 25 to less than 75% of the wound dressing, wound tissues are saturated, moisture may or may not evenly distributed in the wound. Whereas large exudates involves more than 70% of the dressing will be occupied with this exudate. Wound tissues are saturated, drainage is freely expressed from the tissue, moisture isn't evenly distributed in the wound. I hope you understand what is exudate. Exudate is the term given to the fluid which leaks from your wound. Whenever you assess the exudate, assess the color, consistency, amount and water by looking at the wound itself and the post-wound cleansing and debridement and the dressing what we have placed. If we assess the dressing and the wound, then we will be able to identify the amount of the exudate roughly. Next component is the odor. And odor is significant when it is new or when it has changed. though there is no universally recognized scale for measuring odor, we can say odor as strong, very strong, moderate, slight, or no odor. Whenever there is a odor, it indicates there is the infection. So when do you say there is a strong, very strong odor? We can say the odor is evident on entering the patient room itself, that is 6 to 10 feet or 2 to 3 meters away from the patient with the dressing intact. The strong odor will appear on entering the room, again 6 to 8 feet or 2 to 3 meters away from the patient when the dressing is removed. Odor is moderate when it is evident at close proximity to the patient when the dressing is intact, whereas a slight odor will appear at close proximity to the patient when the dressing is removed. And no odor is no odor even at the patient's bedside at the dressing removed. This classification is taken from Hampton and the end 1995. They have described this type of wound odor. So suppose if there is a wound odor is present, we need to cleanse the wound as often as advisable to reduce the bioburden. Ensure the patient is practicing good hygiene. If not contraindicated, increase the frequency of dressing changes so that the odor will be reduced. Change the bed linen as soon as it becomes soiled. Use product designed to decrease or mask the odor like calcium alginate. Use cleansers designed to break through biofilm or bioburden. Use wound cleansing products that are biocides designed to kill odor causing bacteria. And we have to take the appropriate measures to reduce the malodor and reduce the infection rate and promote the wound healing. The next component of wound assessment is the peri-wound area. That means the wound which is present around the area which is around the wound also need to be assessed. The area around the wound should be assessed for temperature, color, integrity of the skin. We need to consider, is the skin friable or macerated when assessing the peri-wound area. The next component is the pain. We can assess the pain using the mnemonic called the LOTAP. L for location, O for onset, T for type, and another T for timing, A for associated symptoms, A for alleviating factors, R for radiation of pain to other part of the body, and P for precipitating factors. The presence and the intensity of pain associated with the wound provides some important information about the wound etiology and the chronicity. However, the degree of pain may not correlate to the extent of injury. Skin tears, for example, can be very painful because damage is confined to the superficial skin, which can expose nerve endings in the dermal layer. Whereas patients with the neuropathic ulcers on the plantar aspect of the foot and concomitant peripheral neuropathy may feel little or no pain, even if the wound is gradually infected. So we cannot say, like, based on the size of the wound, the pain. We may have to think about the size of the wound, the depth of the wound, and the chronicity of the wound in determining the pain. Maybe sometimes the acute wound may have more pain, whereas the chronic wound will not cause any pain at all. So always consider other factors that cause the pain. Hope you are clear with these 14 components of the wound assessment. Let me just list down the 14 aspects of the wound assessment, including both of my videos. The first video covered the location, age of wound, type of wound, tissue involvement, moisture, infection, and wound edges. Whereas the second video, that is in this video, I have covered about size of wound bed status, necrotic tissue, wound exudate, peri-wound area, and odor and pain. So coming to the end of the wound assessment, we can say from every wound there is a scar, and every scar tells a story that says, I survived. If you have a scar, just look at the scar and recollect the wound story. Thus, appropriate wound assessment has an important role play in that story. As a nurse, we have a greater role to assess the wound accurately and to direct the wound care modalities. Thank you. And these are some of the references I have made to prepare the content of my wound assessment video. Thank you for watching this video.